Okay, so before I just give you an introduction to the structure of my talk, I just want to present the problem to you that we face in my field. So anorexia nervosa is it's a very serious psychiatric problem. It carries the highest mortality rate of any psychiatric disorder, about 10% overall, and about half of those deaths are from completed suicide, and the other half are from cardiac complications associated with starvation. We know that we have to intervene early, actually specifically within the first 3 years, because after that point, a person's chances of recovery drop substantially. And there are no known effective treatments for adults. So the treatment that we have for adolescents is a very specific type of family-based treatment, sometimes referred to as the Maudsley model family-based treatment. And it's quite uncomfortable for clinicians to deliver because it's very different to the normal kind of family-based treatment. It was manualized by Dr. Jim Locke here at Stanford and Daniel LaGrange in the University of Chicago. And of course, the real issue is that for community practitioners, it doesn't really make good business sense to spend the $6,000 to $12,000 it takes to train in this very unique type of treatment when you're really only going to see maybe one, maybe two anorexic patients through the course of a year. So the net result of this, of course, is that if a patient with anorexia does not live in the Bay Area or in the greater Chicago area, then usually they don't have access to evidence-based care. So clearly this is a big problem that we need to both scale eating disorder treatment in a way that can be disseminated globally, but also the other problem is that when institutions do implement FBT, that we know that they don't really implement it very well, and that the treatment isn't actually conducted with fidelity to the model. So people aren't even doing FBT the way FBT is conceived of, or the way FBT is done in clinical trials. So I'm going to talk about how massive open online courses, or MOOCs, have done a really good job of scaling expertise and how it maps really well onto standard clinical training. I'm going to show you the solution that we came up with, and then I'm going to just take you through some of the early preliminary data that we have from early feasibility trials. So when we think about standard education, you quickly come to this, what's known as the 2 sigma problem. And what you're looking at is the distribution of knowledge that depends very much on the medium through which it's delivered. So the far right-hand curve there is individual tutoring. This is one-to-one kind of tutoring, which leads to a performance that's a full 2 standard deviations better than the standard lecture environment with the typical sort of teacher-to-student ratio of 1 to 30. In the middle is what's known as mastery learning, which just means that the teacher makes sure that the material is grasped before they move on to the next concept. So how this maps onto clinical training is that we also have the standard 1.5-day seminar. That's what somebody has to attend. They have to attend this seminar before as the first step in their training. And then at the other, we actually have a lower baseline actually, because we presume that some people are just buying the manual and then trying to do the therapy, which could be disastrous. And then at the other end of the scale, we do have full certification, which somewhat maps on to one-to-one tutoring, in that after somebody's attended the 1.5-day seminar, they have to film all of their therapy sessions with 3 to 5 patients, then send those videotapes over to one of the world's few qualified supervisors for individualized feedback on their style and how they could be more fidelitous to the model. As you can imagine, that is extremely resource inefficient, and few people actually go and take certification to this level. Currently, we have nothing in between. There's no real mastery learning. In the 1.5-day seminar, it's the standard teacher-student ratio and all of the difficulties associated with raising your hand and not wanting to look like an idiot like you have in middle school, right? This is the same thing. When I thought about this, though, some of the best trained FBT practitioners in the world are really the Stanford and University of Chicago postdocs. And what's interesting about that is that we don't get individualized tutoring, but what we do get we have peer supervision. We have peer supervision with some, but very limited input from an expert. But what we have is lots and lots of exposure to each other's cases, lots of exposure to the clinical problems and the kind of the unusual presentations that patients come. And so we're building up this repository of experience that is normally associated with lots and lots of years of clinical experience, right? So massive open online courses can actually emulate this environment of peer exposures in a way that's really unique and in several key ways, basically. The platform that we're using is called NovoEd, and it actually is built specifically around this peer learning environment. So what that means is that the learners sign up to the course in a cohort, they do their exercises together, they solve clinical problems together, they're learning from each other, and you're getting lots of exposure to each other's clinical cases that way. Also, the centrality of video, of course, is something that really helps with this exposure kind of idea. Obviously, in addition to the didactic videos where we have Dr. Cara Fitzpatrick, who's one of the world's foremost trainers in this model, she's giving lots of these small, less than 7-minute in length videos training specific concepts. And actually, the length of the videos mirror on nicely to discrete concepts in this training. But we also have, we're building a repository of role-played sort of scenarios. So we have whole role-played sessions, and we have lots of different instances of things that can go wrong in an actual session and how the therapist is dealing with them. So again, we're building up this experience, I guess, or an exposure to all the different kinds of nuanced clinical occurrences that can happen. Also, the really neat thing about MOOCs is that it allows, for the first time, a way to leverage assessments that can really, really benefit learning. So we have assessments that can facilitate basic mastery. In other words, we can just stop the video and ask a question, and the person must get it right to move on in the video. And that's a basic check that they're listening, although we do know that that enhances learning. And that enhances a specific kind of learning, like declarative knowledge. That's sort of rote learning, which does account for about 30% of knowledge. The other 70% of knowledge, though, is related to critical thinking, and that's sort of the experiential, the much deeper level learning. That's like putting yourself in the shoes of the clinician and really thinking through and doing. Both of those opportunities are completely missed in our standard, lecture format seminars. So we're able to do that. Another interesting feature is that in MOOCs, is that the finding that actually self-grading and peer grading is actually not that dissimilar to expert grading or the teacher grading. A lot of teachers are actually quite uncomfortable with this slide, but a really interesting concept, and we'll have to see whether this bears out in our platform. But the point is that when you give the peers your peers an opportunity to really evaluate your work, they are putting themselves in the shoes of an expert. And so that arose out of a necessity, just a logistical necessity in MOOCs, because you can't grade the work of 200,000 students. So they had to implement this policy. But in psychiatry and in academic medicine, we're no stranger to peer review, so it actually mapped quite nicely. The really key, very interesting part of this for me is that now, for the first time, we have access to a lot of data, and the data can actually help us feed into newer models of learning, because we can actually look at how people are learning. And I'll talk about that a little bit more later. I apologize to anybody who has motion sickness, by the way. So this is what our platform looks like. We have a 12-week course that is 6 or 7 lectures in total. And they're a combination of the didactic lectures, again, less than 7 minutes in length. And then they each have some clinical role-played sessions as well. We can upload lots of rich material. We have a description of the assignment, and we prescribe readings. And also, we have uploaded lots of, we've borrowed from concepts of case method teaching, basically. We've uploaded all the clinical content that would come with a patient, and this matches our role-played patient that the trainee follows throughout the course of the training. So we have their intake evaluation, a score sheet from a standardized interview there, which all complete with, you know, doctor's scribbles, and then the weight chart, which is uploaded each week, so you can see the progress of this patient and they can think through it. So in addition, all of our assessments are based around this role-played patient, so that, again, the trainees are really rolling up their sleeves and thinking through this as if this was their patient. In this case, for this assignment, they have to look at the video of a clinician implementing a specific intervention, and they have to rate how well she does this. We actually give them the rubric that they will use to rate how well she's doing implementing this intervention. And so we're operationalizing what it looks like for a therapist to do a good job, basically. This is adapted from a fidelity measure that we built, and actually that we'll be judging them later on their own clinical skills. So again, sort of giving them the experience of being the expert themselves, stepping into the shoes of somebody judging a good therapy. So let's look at, well, what do the clinicians like this? So since August, wow, that's really huge. Since August last year, we've conducted just 2 pilots, a total of 44 trainees. So these are not launched as MOOCs. They are not publicly available. They're launched as small private online courses. So we're using the platform, but it's not public. We have a completion rate of about 38%, which is actually, you know, that's not bad. What that completion rate means is for everybody that counts everybody who did every single homework assignment, and it was really quite involved. In the first iteration, they were quite experienced clinicians. They'd had about 7 years of experience working with an eating disorder patient. And the second cohort were mostly just residents, very, very new in clinical training. You can see there a nice kind of breakdown of MD psychiatrists, PhD psychologists, and MFTs, that's master's level family therapists. So, do they like it? Most part, they did like it. So this is overall satisfaction. I'm going to fly through these. They really, really liked the didactic lectures. And this doesn't surprise me. And the feedback I was getting was that we can, you know, they are able to go back and revisit specific concepts and constructs and play the video a million times, because Cara speaks very quickly, quicker than me even, and you know, she packs in a lot of information into every sentence. People also really like the clinical content, and the homework, definitely a little bit more neutral about that, and certainly very neutral about peer review. That's interesting, because when we looked at the feasibility data, like, these are people who are using social media, but they don't love the peer review aspect, and so that's something that we've really got to visit. We asked the clinicians, gave them an open-ended question: what was the greatest challenge for you to complete the training? And 70% of people said time. This is mirrored when we actually look at, like, they're all doing it. Usually, most part, people are doing it at the weekends, and the vast majority are doing it late in the evening, so not ideal for learning, right? So this is something that I think we're going to have to absolutely examine when we roll out our NIH trial in the next couple of weeks. I think we need to have institutional buyout for the time. So, because, you know, you can get your institution to allow you to do a two-day training, but it's different if you're expected to do 3 hours a week for the next 12 weeks. So that's something that we never really anticipated, but we'll hopefully do. For this trial, we've also had to invent lots of weird and wonderful ways of assessing each other, and it's pretty neat. It's already led to kind of some innovative methods that we've been able to validate, such as we've videotaped very short clinical vignettes, and we video conference in the trainees, and we have them respond to the vignette as if they're in the room with the patient. But the other thing that we really need to do is work on the peer engagement piece, because we're potentially missing all of this huge opportunity for a lot of learning through kind of debate and discussion. A few words on the potential, and then I will finish. The thing is, for me, the really exciting piece of this is absolutely the data that we've generated. Even in these 2 short pilots that we have run with just 44 people, we've been able to feed the data directly back in and amend something really quickly, iterate it really quickly, and roll it out again in a matter of like turnaround of a week. It's fantastic because standard clinical training for this model has remained static for years. So when we really get this up and going, I think, and have like actual community practitioners, it's going to be really fascinating to see where it goes. And it's inevitably going to lead to some really interesting innovation. And I think the key to this is better access to treatment globally and being able to disseminate treatments to, across the globe. Hopefully this is going to lead to improved patient outcomes and just fewer clinicians just being isolated with it holding only a manual. So thank you. Yep.